I always like to spend time with our next speaker, Sandy McDonald, a real Canadian hero. I was trying to interpret ultrasound performed after treatment, and I really struggle with it. It's not quite the same as it is when the patient hasn't been treated. So I asked Sandy to speak about ultrasound, give us the latest review, and to share some thoughts on the nature and meaning of the ultrasound after treatment. Sandy?
Thanks, Sal, and thank you for putting on such a great meeting. We all certainly appreciate it. There we go. I'm doing better than Chicago already. When we were in Chicago, we had a little AV problem when we did this 3 times to get it right. Anyway, I'm Sandy McDonald. I'm from Canada. I have no financial relationships to disclose. I must admit, though, I'm not very popular with the neurologists in Canada, so there are some conflicts that exist. CCSVI is a controversial hypothesis. The diagnosis is controversial, its existence is controversial, its treatment is controversial, and when you treatment, its follow-up is even more controversial. Sal asked me to talk in part on the follow-up after, and I reviewed the literature and I tried to find any good studies that commented on how you should follow it up after, and there aren't any good studies that I could see. MS, we all know that it is prevalent in Canada. It's got one of the highest prevalence rates in the world. The US is 350,000, Canada is 75,000, but our population is roughly 1/10 of the US, so our prevalence is much higher. It was first described by Charcot, or almost by Charcot, and then it was described by Tracy Putman, and the perivenular aspect of it by Tracy Putman is well known by everybody. The next study, however, is by a Bulker. And a Bulker was in the 70s, and that was before we had MR and before we had CT. And a Bulker's group out of France looked at the incidence of venous anomalies in people with myelopathies, not MS. And when you actually look at his data, it's intriguing because the next slide is going to allude to Zamboni's stuff. But if you look at it, he had iliac vein, renal vein, azygos, brachiocephalic abnormalities, IJV atresia, and compression of the vena cava. Now, he didn't have the tools that we have now. He had surgical intervention. So he operated on a bunch of these people. And lo and behold, after he corrected the venous anomalies, he found that the significant, or the majority, statistically significant number of the myelopathies got better. Put this slide up. This is one of Zamboni's slides. I'm going to go back and forward here for a minute. If you look at a Bulker's work, he talks about the iliac vein, the renal vein, the azygos, brachiocephalic, IJV atresia, and vena cava compression. This is 40 years before Zamboni. Now you get into Zamboni's, and this is 2010. We look at the IJV on the right, 80%, IJV on the left, 94%, azygos, 71%, hemiazygos, 23%, renal vein, and so on. So the work is incredibly similar for different technology 40 years apart and no conflicting interests between the two groups. I brought up Zamboni's criteria, and this is a really important slide. If you look at the players that have written the NAY journal comments, they've said that they have repeated these studies according to Zamboni's criteria. And I would respectfully submit that I don't think they read Zamboni's paper. Zamboni talks about reflux, and it's reflux in one or the other of the IJV or VVs in both the supine and upright position. So he talks about it being constantly present. It doesn't mean it's constant throat, but it's present in either position. He talks about reflux. Reflux is difficult to see, and Karen Marr talked about that a few minutes ago. The reflux is hard to determine, and doing the study is difficult, but if you take your time and actually do it, you can see other anomalies associated with the deep cerebral veins. High-resolution B-mode abnormalities are easy to see, but hard to assess. And if you look at the paper by Meyer et al., they actually look at the venous anomalies, and they say, well, they have difficulty assessing the size and the extent of the stenosis. If you talk to the radiologist that works with Dr. Zamboni, the way he determines the stenosis isn't just by a static image. He puts a catheter, a compliant balloon inside the IJV, opens up the compliant balloon, and by the appearance of the compliant balloon, then determines if he's got a stenosis or not. So it's not even using catheter venography, he's using catheter venography plus a compliant balloon. Flow not detectable by Doppler. And the next slide is going to get into this a little bit more. And what that means is you put your Doppler probe inside the IJV and you look at the flow. Part of the problem with that, and Karen alluded to this, is you have to set the PRF on your probe appropriately. If you set the PRF too high, you won't see flow. And what you have to do is set the PRF down to about 0.5. And if you set the PRF at about 0.5, then you either see flow or you don't see flow. What a few of the naysayer players did, instead of doing that, they actually set the flow parameters lower, and they said, well, there still is a little bit of flow. And what Zamboni said is a reasonable flow or no reasonable flow, not is there a little flow or no flow. And when I talked to some of the folks in Canada, I said it's like when you go up Avenue Road on a Friday afternoon. On Friday afternoon, you can say the traffic isn't moving because you go a block in about an hour and a half. But if you talk to the naysayers, well, say, you did go a block in an hour and a half, so there still is flow. So it's a little bit different. It comes down to relativity at that point. And the last one is an interesting. It talks about the change in the cross-sectional area of the jugular vein in a supine on an upright position. If you read Paolo's paper carefully, he says he never saw a cross-sectional area of less than 0.3 centimeters square in a normal person. But if you go on to other papers, they're going to contradict this. This is a series of 10 papers that I had a look at. The first one is by Dr. Zamboni. He looked at 65 patients. His is the only so far paper that's been published that actually looks at treatment and outcome. There are other papers that are produced. Robert Zavadnov, who's sitting here, had a great paper. And some people say it's yay or nay. I think it's actually a very positive yay paper. He found that there was a 56% incidence in CCSVI in 268 patients. That's a big number. At the same time, he found 22% in normals. That's not a very big number, bigger than what Zamboni had, but not a very big number. The other papers used sometimes the same modality. They used extracranial duplex, as alluded to over here. Yamut did a small study, 42 patients, and on that he used selective venography. Then Barrie had an A paper, but his A paper only looked at clinically isolated syndrome, didn't look at anybody else, and he used Doppler plus selective venography, and the rest are as indicated. On Robert's paper, Robert Zavadnov, he did 499 patients, a big paper. On those, he had 289 MS, 163 healthy controls. One nice part about the paper, he's looked at 115 patients that were first-degree relatives, I believe they're first-degree relatives of patients with MS, and he found in those, comparing them to normals, there wasn't a difference, which is an interesting statistic. He looked at 21 CIS and 26 other neurological diseases. But the end result is 56.1% had more than 2 criteria. What he did in the assessment of the data is that if somebody was borderline, he put them in the other side of the equation, which in theory increases the statistical significance of the findings. On the study that Robert did, he used 5 of Zamboni's criteria in 75% of the patients and 4 criteria in 25%. And the reason this was done is, I believe, on the criteria number 2, they had some trouble with some of the images in terms of assessing flow or no flow, direction of flow, and so on, so they excluded them because the data wasn't as good as it could have been. The net effect from Robert's paper is people with MS have a significantly higher prevalence of CCSVI than people without. Depp is a world-recognized sonographer. And he published a paper, and the title I've alluded to, no cerebral cervical venous congestion in patients with MS. He looked at 56 patients, 41 with relapsing remitting, and 15 secondary progressive, and he had 20 healthies. And if you look at the end result, not very good. He didn't find any with 2 criteria. And then one has to ask, well, why didn't he find any with 2 criteria? Well, he didn't use the same diagnostic techniques. What did he do differently? He assessed the flow right at the angle of the mandible. Not necessarily a good thing. Karen talked about that a little while ago. What you want to do is assess it down at the base of the neck at the brachiocephalic or IJV junction. What he then said in his paper is, if you look at the upper part of the neck, and he quotes Ekanoff, and there are other authors that have found the same thing, the blood flow volume capacity at the base of the skull is about 1,000 ml. So if you then take this data and compare it to other folks that have done, like the Sundstrom paper, who look at the MRI data of flow right at the base of the neck at the C1, C2 level, it's understandable why they got a negative result, whereas if they do, as what Mark Hakey suggests, do the study down at the C6 T1 level, you actually get a positive result. What Depp did, in order to determine if there was reflux or not, he did Valsalva maneuver in 100% of patients. Zamboni says you never do Valsalva maneuver. And his last criteria, criteria 4, which I call block, which is no flow seen. It doesn't mean there isn't blood in the lumen, but there's no flow. What Depp did, he said there's no flow detectable in both IJVs and or both vertebral veins. That isn't Zamboni's at all. Zamboni's is you don't see flow in one of the veins. So again, the reason Depp's study doesn't match is he really didn't use the same criteria. Another interesting finding, and I'm not going to jump all over Depp on this, but this looks at a study done by Depp, published in the Lancet 2000. This is a study done by Depp as one of the authors, studies in the Annals of Neurology 2010. And if you look, this is the healthy German population in 2000. They had 700 ml, 270, compared to the same person doing the same type of investigation 10 years later. Clearly there may be a small problem with technique. This is Dr. Simka's data. Dr. Simka's here, and he can tell me if I've made some wrong assumptions, but if you actually look at Dr. Simka's data, it correlates fairly nicely with that of Dr. Zamboni. And if you go to the end result from his paper, he then went on to selective venography, and with selective venography he confirms this, but the conclusive analysis that Dr. Simka made is right here. He found that conclusive analysis shows greater than equal to 2 positive criteria in 90% of patients. Dr. Simka then went on to catheter venography, and his catheter venography showed abnormalities in 97.1%. Meyer then decided that he would write a paper, and this was heavily published, and it made the Globe and Mail, I believe, in Canada as well. And what he did is he looked at 20 patients with MS, 17 relapsing and relating, 13 secondary progressive, and 20 healthy controls. And again, if you get into the paper, he says that he used exactly the same criteria that Paolo Zamboni used, but when you actually get into reading the paper, you got to read the fine print. It's like the adverts on TV for Ali and so on. You got to read the fine print, because when you get into the fine print, what they did was for criteria number 1, and Karen alluded to this a few minutes ago, you don't use a longitudinal plane, you use a transverse plane. Well, these guys used a longitudinal plane. And criteria 2 for reflux, they decided they would use criteria that were published in other literature, not Zamboni's literature. They used the same reflux, but they used totally different criteria for determining how they're going to do the assessment. And criteria 4, they had lack of detectable Doppler flow in both a supine and an upright position. Again, totally different criteria. And then they come up with the final conclusion, and the final conclusion was sort of interesting. It talks about a tight endothelium that is non-permissive to cells. I think we'd all have to agree with that, because we see T lymphocytes traversing the tight endothelium in MS all the time, and that's sort of part of the accepted theory that the T lymphocytes are part of MS. And then when you get into a little bit further, he talks about the fact that there isn't any increased iron in the CSF in terms of ferritin in patients with MS, and that was by a guy called Worthington, and this is where it's published. Going on to another paper, this is Yamut, and Yamut did a paper. He did selective venography. He looked at 42 patients, 13 with late MS, 29 patients with early MS. He was trying to compare the difference between one and the other, the early versus the late. Now, for an early MS, they could have relapsing remitting MS, and they could have it for 5 years or less, or they would have MS for greater than 10 years as determined by late. And his results are interesting. And again, he used no normal controls. His early MS, 7 out of 29 were positive, but in his late MS, 12 out of 13 were positive. And his conclusion was, if you go through all of it, it says functionally that there must be something going on in the brain of the people with MS, and something goes down through the veins and it causes changes inside the veins. That was a little bit hard for me to swallow, but could be. Going on a little bit further, we get to Dr. Elamari's study, and if we get to the final result, he actually again strongly suggests that there's a prevalence between the two, CCSVI and MS. He had a 92% showed abnormalities, so pretty high. This is a study done by Bastianello. Part of his data was presented in Bologna earlier this year. I'm one of the co-authors of the study, and what we did is we had 6 centers and we pooled our data and then did a paper. I think it's currently the biggest ultrasound study that is hopefully going to be published pretty soon. And what we did is we had 805 patients in the study. Of the 805 patients, we had inadequate or incomplete data on 95 patients, and the incomplete data alluded to the history of their MS. So those 95 patients were excluded. Once those 95 patients were excluded, it left us with 710 patients. Different modalities in terms of equipment was used. SAOT is the machine that was used by Paolo Zamboni, but not everybody used an SAOT. Some used a general a GEP5, that's what I used, and others in Italy used an IU-22 Philips. The SAOT at that time was not HPV approved for the for Canada, or FDA approved for the US, and I think that's been changed. And of the patients we looked at, these are the numbers. 388 relapsing remitting, 227 secondary progressive, 95 primary progressive. These are the individual data from the 6 centers, but the number that is the important number is the bottom number on the right. The bottom number on the right, we had an overall prevalence of positive 2 findings on 86% of the people. Clearly positive. Then when you break it down, the questions that were raised is, when you look at the higher EDSS scores and a higher age of onset, it pointed to a higher probability of the presence of CCSVI. That's statistically significant. These are the, oh, I did that one wrong way. People with a higher EDSS score tended to have a higher prevalence of CCSVI. I was going to break away and go from ultrasound to catheter studies, and this was presented by Dr. Mehta a little bit in Bologna, but it was presented to the Society of Vascular Surgery on June 19th this year in Chicago, and Dr. Mehta looked at 150 patients. He used catheter venography. And again, going back to Dr. Simka's study, Dr. Simka had greater than 90% abnormality, and the guys in Albany had a 90% probability of a stenosis. They looked at their complications, and their risks at 4 months were occlusion rate of 2%, a restenosis or stenosis rate of 9%. But the key to their study, which is great data, is the change in the MSQOL 54 score. And the MSQOL 54 score was scored by an independent physiatrist. They started out with a score of 40.2, and when they were reassessed, they had a score of 59. The higher the score, the better off they're doing. The conclusion from this was that there's a strong association between MS and CCSVI. The complication rate was low, so they said angioplasty is safe and associated with improved QOL. The difficulty with this is it's not randomized and it's not blinded. I'll leave that slide. Leave that slide. This is a slide that I borrowed from Mark Hakey's work. And if you go back a few minutes ago, I talked about the authors that said there's no increased ferritin in the CSFs of patients with MS. But this is one of Mark Hakey's slides where he quantifies iron in the thalamus striate. Right is a normal brain, pardon me, left is a normal brain, right is a patient with MS. And Mark has done this in a specific technique so the presence of iron is marked, and this is statistically significant. I wanted to put up a few slides that we look at when we have patients with MS. This is one patient with relapsing remitting, age 45, and the criteria are sequentially 1 through 5. So the patient has reflux, he's got accelerated velocity. We don't see reversal of flow, but we see significant augmentation of velocity in one part of the respiratory cycle and no flow in the other part of the respiratory cycle, which Paolo thinks is probably saying essentially the same thing. This is a B-mode abnormality. You don't see it very well. And then we go to block. This is the no flow. Then we do cross-sectional area. The cross-sectional area, the numbers are small. I apologize for that. The cross-sectional area is 0.04 centimeters squared in the supine position, and in the upright position, 0.27 centimeters squared. This person scored 5 out of 5. Oh. Patient number 2, same idea. He's got reflux, accelerated flow, B-mode abnormality, no flow, and the PRF is set properly. Then we see the cross-sectional area in the supine versus the upright, and in the supine position, the cross-sectional area is significantly smaller than in the upright position. Oh, wrong way again. This is a nice example of a septum, and if you go to a cine film of a septum, you actually don't see movement of the septum. Part of the problem with all of the criteria is assessing what the abnormalities really are and really mean, because if you get two sonographers looking at the same abnormality, you can get a difference in interpretation. And there's only been one paper written by that, and that was Paolo Zamboni and Erika Mainangati's paper, where they used different sonographers and actually proved the same finding. This is a normal cross-sectional area. The slide on the left has a cross-section area of 0.37, that's supine, and upright 0.27 square centimeters. And this is a nice example of the left IJV with reflux, right IJV with reflux, and a normal on the right side. Nice example of block. Again, the PRF is set properly. We look at this through part of the cardiac cycle, and we see no flow. This is a cine. And I don't know if you're going to see it very well, but this is a valve cusp. Oh. That just doesn't move. Oh, it's not going to cooperate. Oh, we'll do it again. There you go. That's exactly what we see. And if we get the image twisted a little bit so we see the other valve cusp, we see that there's no space between the two for any flow to occur. This is a patient post-angioplasty. So even though we've done the angioplasty, we haven't fixed the problem with the valve. That really raises the next question, and I don't have an answer for the next question. The next question really is, what criteria should we be using to assess the flow after the patient has had a procedure? I don't know the answer to the question. I haven't found anything in the literature that alludes to treating it one way or another, or dealing with the literature one way or another. So what I've been doing is I use exactly the same criteria that Zamboni used in his original paper, and we're doing the study exactly the same way, as closely as we can to mimic it. This is a nice study. If you look at the time, we've gone through 3 cardiac cycles, and through 3 cardiac cycles, we've seen reversal flow in the jugular vein. I'm just going to go back and then I'll go forward again because that's the way it works. But if you look at it, 3 cardiac cycles, and we see continuous reversal of flow in the jugular vein, with the jugular vein being here. I'll do that one more time just to convince you. This also is a patient that had a venoplasty. And you can see the, I'll leave this one. This is a patient that had a venoplasty done recently. It was done actually in early June, and we did the study in late June. And you can see on this that we have absolutely no flow through here. And if I had other images of it, you would see that that IJV has been a stented IJV. So it's 1 month post-plasty. The patient's been anticoagulated, and despite anticoagulation with a stent in place to keep the vessel open, we have no flow. which raises another issue, and I don't know the answer to the question. And the question is, how often should we be studying them post-procedure? What anticoagulation protocol should they be on post-procedure? I don't know the answer to either. What we've been doing is we study them 3, 6, 9, and 12, and with that we've seen a very low incidence of recurrence of stenosis. We have seen an incidence of fibrointimal hyperplasia, but again, the number of blocks or occlusions that we've seen are relatively small. I don't have enough that I can actually quantify the number of restenoses or that I can quantify the number of occlusions because we can't get all the data correlated. And that really speaks to the final issue in that there has to be collaborative studies done, not just like me working by myself in Barrie, but so that all of us are actually working together so we can quantify the data. For instance, if I do the ultrasound in Barrie and Dr. Simka does the venoplasty in Poland, then we can correlate our data and actually see if the ultrasound is accurate and coincides nicely with the findings that he sees on venography and on his MR pre and post. If we did that, I think we could collect the data and get it done fairly quickly. And this is a statement from Tracy Putman, and it's oh so true. The story of multiple sclerosis is not yet closed, but neither is the history of medicine. And Tracy said that in 1938. From the 50s on, we've been looking at the autoimmune problem associated with MS, but the real question is it autoimmune, is it vascular, or more likely, is it a combination of both?